Alterations in mobility, orthopedic treatment. A cast is a rigid mold that will immobilize an injured structure when a fracture does not require surgical reduction or manual manipulation. However, they can also be used with fractures that do require surgical manipulation. Types of casts include a cylinder, which will leave the distal structures exposed, such as the fingers or toes. A body cast, which is a cylinder cast that actually encircles the trunk. A hip spica cast, which surrounds one or both legs and the trunk, that have openings for anal and the genital area to allow for elimination. And those spica casts or any cast can actually be strengthened by a bar. Casts are made of fiberglass or plaster of Paris. They're going to align and support the fractured area. That cast material will feel warm during the application, and it's really important to allow that to dry appropriately before it's handled too much. So we usually will support a drying cast on a pillow. A cast window might be cut in the cast. Basically, it's cutting out a portion of the cast to allow direct inspection of an area that's under the window. The window will then be replaced and secured with maybe a gauze or ACE bandage. We can also cut a window, let's say there is a laceration or they did surgery or the client reports discomfort or there's a wound under there that requires a regular dressing change, etc. A bivalve cast is where a cast is cut in half. We can do that if the limb becomes swollen to the point where it's beginning to affect circulation. We can do it when the client is being weaned from the cast, so they leave it on the majority of the time, but they can take it off periodically for various activities such as sleeping or maybe bathing. We can do that when a sharp x-ray is required, or we can do that if it's being used as a splint. Cast removal will be done with what we call a mechanical cast cutter or a cast saw. The skin appears mottled after a cast comes off, and it may have a yellowish crust or atrophied muscle underneath it. Now, if we have that yellowish crust, we can apply lotion and do warm water soaks to help remove that dead skin and help rehydrate that skin. And reassure the client that the muscle is going to beef back up with exercise. Now, there's a couple of things that we need to also keep in mind. Something that's becoming very popular are going to be casts that can actually get wet. So they're designed to get wet. If you review the PowerPoint in your optional activities, it will actually have a picture of the material that is used to pad the cast. It's actually allows the cast to get wet. In fact, it's encouraged that these casts get wet. They can go swimming with them. They can shower with them. They are instructed to hold that cast in the dependent position after getting it wet to allow the water to drain. But this can actually help the skin and help with any odors and itching issues from that dead skin. We also need to encourage the client to help improve circulation by wiggling the fingers, wiggling the toes. This is going to help reduce not only pain, but it's also going to help reduce edema and, like I said, improve circulation. So, true or false? When a limb is placed in a cast, the joint is set to straight to assure bone alignment. And that's false. When it's placed in a cast, the cast will be applied from the joint above the fracture site to the joint below the fracture site. And that joint will be slightly flexed to help decrease joint stiffness. The next type of treatment we have are splints and braces. Splints are going to immobilize and support an injured body part in a functional position. It can be made of plaster of Paris or a pliable thermoplastic material. It should always be padded to help prevent skin impairment. And then we secure it with an elastic bandage or Velcro straps. Braces are going to provide support. They also control movement and help prevent additional injury. They provide the client or make sure that you provide client and family education on when it should be worn, how it should be placed, etc. Braces can be made of plastic, canvas, leather, or metal, and they can be custom fit to the client. True or false? Braces provide support, control movement, and prevent additional injury. True. When we reduce a fracture, this is the process of restoring the proper alignment to the bone. The method of reducing the fracture will be dependent on the first aid that's provided, the location and the severity of the fracture, and the age and overall condition of the client. It can be done with cast application. It can be done with traction, which will pull the structures of the musculoskeletal system to help realign that break. It does also involve a counter traction. Traction can help relieve muscle spasms in addition to aligning the bone and maintain immobilization. The type of traction would include skin, which involves a device that goes through the skin, that's applied to the skin, such as a boot, and skeletal traction, which would involve pins or wires being inserted into the bone and then the weights appropriately applied. If you look at your picture here, we have a picture of Buck's traction. This is a type of skin traction. You can see that there is a boot applied to the client's lower leg, and we have the weight extending from a pulley off of the end of the bed. It is so important with traction that we make sure that the ropes are free and that the weight is not resting on the floor. But also consider we're pulling on the client's leg so we can easily pull the client to the end of the bed. And if their foot is in contact with the end of the bed, we're not getting appropriate traction. So it's very important to not only assure proper alignment, we need to make sure the weights are hanging freely and that the ropes are free and move easily in the pulleys. And we need to monitor for skin impairment. A closed reduction would require external manipulation of the bone prior to immobilization. An open reduction, we have to cut them open. So it's the surgical exposure and realignment of the bone. Internal fixation would be that open reduction, but now we're also going to stabilize the fracture with plates, screws, rods, nails, or pins prior to immobilization. This is going to be the process that's used if there's significant soft tissue injury, wide bone separation, if it's a comminuted fracture, if the patella or other joints are fractured, if we have an open fracture, or if wound debridement is required. And then we have external fixation, which involves the insertion of metal pins in the bone. And the pins are applied from the outside skin surfaces. They go through the skin into the bone, and then we attach an external metal device that is actually very firm, and it stabilizes and positions and immobilizes that bone. It's really important when we do have a skeletal traction or an external fixation device to monitor the pin sites for sites of infection. Orthopedic surgery is another type of care that may be provided to correct a deformity, remove a primary bone tumor, align fractured bones, or repair or reduce a split, or replace a joint, insert bone grafts, stabilize a bone internally. So an ORIF is going to be that open reduction internal fixation. We frequently will do this, for example, for a hip fracture. Bucks traction may be required if surgery cannot be done immediately. It may require those nails or intramedullary rods, plates, or wires, and it holds those bone fragments in place until the bone healing is complete. Now, that doesn't mean that we're going to actually go in and start removing all of this hardware once the bone has healed, but sometimes we will do that. But a lot of times those are just left in place. We can also do surgery for joint dysfunction correction. This would include an arthroplasty, which is reconstruction, and usually of the knee or the hip, and it could also be a procedure called arthrodesis. We can do an osteotomy, which is where we remove part of that bone, and that would be a procedure called a hemoarthroplasty. A total arthroplasty is another procedure. Postoperative complications would include hemorrhage, dislocation of that artificial joint, infection, thromboembolism, and avascular necrosis. Postoperative nursing management. It's really important to get that complete history so we know what's going on, or preoperative. Assess complications from any previous treatment. Assist in reducing pain, risk of infection, and increase the client's mobility. And help control anxiety and help the client understand instructions. Postoperatively, there may be some required demonstrations, for example, wound care. Be sure that you are monitoring any post-surgical devices. Reduce the risk for excessive bleeding. We always need to look at the provider's orders. After a knee surgery, we may place a continuous passive motion machine on the client to help improve the flexion of that knee joint. We need to help reduce pain and inflammation and prevent postoperative complications. So that means you're churning, you're deep breathing and coughing, etc. As far as teaching, Make sure that we know what type of support system they will have after discharge. And not only the caregiver, but also the patient will need this education. Determine what type of assistance might be required. Are there any modifications that will be required in the home environment? What type of home care might they need? And refer them to that home health care agency if necessary. And as always, we would give printed discharge instructions that would include activity, physical therapy, and symptoms that need to be reported. With a hip replacement, there are some precautions that need to be done to help prevent dislocation of that new joint. So we need to have the legs abducted, in other words, separated with pillows or an abductor cushion, and extended because of the opposite positions of adduction and flexion beyond 90 degrees can actually cause dislocation of that prosthetic femoral head from the acetabulum. The clients need to sit in an elevated chair or on a seat that's raised by pillows so their flexion remains less than 90%. They should not bend more than 90 degrees at the hips. With knee replacement, these clients are going to have the amount of flexion and frequency of use increase daily while they're still hospitalized. And that's where the CPM machine comes in. So the goal is for the client to have the ability to bend that knee 90 degrees by discharge. The amount of flexion for clients with hip replacements should never exceed 30 degrees in a CPM machine. And we should always instruct the client to never cross their knees. Amputation is the removal of a limb due to trauma or to control disease or disability. Amputation rationale can include a malignant tumor, a long-standing infection, extensive trauma, death of the tissue, thermal injuries, limb deformity, or life-threatening disorders. A traumatic amputation is when part of a limb is removed due to an accident. In other words, that body part has been removed from the client during an accident. In some cases, the limb may be damaged severely enough that the limb, even though it's still attached, has to be amputated. Trauma is going to be the most common cause of amputation of upper extremities, while the most common cause of lower extremities is going to be disease, infection, or poor circulation. If it is a traumatic amputation, that severed tissue needs to be wrapped in a clean cloth, saturated with normal saline or lactated ringers, placed in a plastic bag, and then place that plastic bag in ice water. If the body part is only partially amputated, leave the body part in place. So this is the emergency care of an amputated body part in the hopes that it can be replanted or reattached to the client. So the limb or tissue during an amputation would be removed to the lowest level where there's healthy tissue and good blood supply, and is going to also promote the fitting of a prosthesis. The description of the amputation will be at the level that the limb is amputated. So, for example, below the knee amputation, above the knee amputation, etc. Amputation methods include an open or guillotine method, a closed method, which would have a skin flap, and staged, where it's open at first and then later the wound is closed. Postoperatively, we're going to put compression sleeves on to help shrink that stump. So it's sometimes called a stump shrinker. It's also going to help reduce bleeding and edema. It could be just an ACE or elastic bandage, or it might be a plastic shell that's placed over the stump. So again, reduce bleeding and edema, but in addition to that, it's also going to help prepare that stump for the fitting of a prosthesis. So the client can be fitted with prostheses as soon as that surgical wound has completely healed. Complications of amputation include hematoma, hemorrhage, infection, a stump neuroma, where the nerve ends become tangled in the scar tissue, phantom limb sensation, which is they have the feeling that the limb is still there, or phantom pain, where they're feeling pain in the limb that's no longer there. This can actually affect the client's ability to use a prosthesis and may require removal of nerves at the end of the stump. Always, always, always treat phantom pain as real pain. If they complain of pain in a foot that has been amputated, it is pain in the foot. So, but we call it phantom pain. So they're going to get analgesics just like anyone else, determine the level of their pain, etc. Replantation is going to be the reattachment of an amputated body part to a limb. It not only requires that reattachment, we have to reconnect blood vessels and nerve fibers, and then finally the severed limb. Transplantation of donor body parts is becoming a more common practice with amputation. Crushing injuries or avulsion injuries in which that limb is mutilated, unfortunately, are not going to be appropriate for replantation. Post-replantation, we're going to do our normal postoperative care, of course. We need to reduce edema by elevating that limb to promote not only venous, but also lymph drainage. But we should not elevate it above the level of the heart. These clients should not have anything that is going to be vasoconstricting, such as nicotine or caffeine or cold temperatures, etc. Clothing needs to be loose so it will enhance circulation. We need to keep the environment at least 80 degrees. These clients are also going to require anticoagulation. But if we do see venous congestion, which is going to be a significant swelling in a replanted part, we have to treat this. We have to get rid of that extra um, venous blood supply. And one way to do that is medical grade leeches. Rehabilitation factors are going that will affect the success of the amputee are going to be dependent upon things such as the client's age, their physical status, etc. And we have to keep those realistic expectations individual because not everyone is going to have the same uh, possibilities for rehabilitation. So again, nursing management with pre and post-operative care, we have to monitor the diseased, injured limb, stump, etc. for circulation, pain, keep that limb elevated, etc. Let them know what their surgical expectations are and provide emotional and spiritual support. I mean, this is a significant life-changing event. And of course, provide appropriate wound care. By the time of discharge from the hospital, a patient with a knee replacement should bend the knee how many degrees? 90 degrees. Something I want to briefly touch on, we have crutches and we have walkers, and we need to know the appropriate way to use these. With crutches, the crutches should not be touching the axilla. We should be able to put 2 or 3 fingers um, on the arm rest and under the arm. So we measure the crutch height by putting the crutches approximately 6 inches in front of and 6 inches to the side of the client. And then again, make sure that we have 2 or 3 finger widths between the top of the crutch and the armrest. The client's weight should always be on the hands, so it does require upper body strength to be able to use crutches. When you're going up the stairs, it's always up with the good. So you're going to take the good leg up first, then bring the bad leg up. When you're going down the stairs, it's up with the good, down with the bad. So when you're going down, the bad leg goes first, then the good leg. When we're using walkers, make sure that the client is pushing or lifting the walker just a few inches in front of them, walking into the walker. Then they lift or push the walker ahead a few inches, walk into the walker. Do not let them push that walker so far in front of them that they become unbalanced. That will create a fall risk. When they're getting up from a chair with crutches or with a walker, they always want to hold the crutches in one hand or hold on to the walker with one hand, reach back for the chair, and then lower themselves down. And then they would get up just the opposite.